Good evening. I am Ángel Sánchez Recalde from Monica Hall Hospital. This is our fifth webinar about physiology and coronary imaging. And I'd like to thank, as always, Abbott for sponsoring these webinars. And this is the last in this year. And today is a honor and a pleasure to have with us Dr. Carlos Collet. Carlos Collet is the co-director of the Cathlab in Aalst in Belgium, and is one of the biggest experts in the world in physiology and also in coronary imaging. And he will talk about the future, about the future directions in coronary, mainly in coronary physiology. And the presentation is about 25 minutes and then questions. And in the second part of the webinar, we will present a live case. And also it's a honor and a great pleasure to have with us today Fernando Rivero. Fernando Rivero is the director of the La Princesa Hospital, also in Madrid. And we will discuss the findings in a live patient. So without further delay, Carlos, thank you so much for accepting our invitation. And as you want, you can start your presentation.
Michael, first of all, thank you very much for this invitation. I'm very happy to be here. And I will start right away sharing my screen so we have enough time for any questions at the end. And I was asked to discuss a little bit more with you about the future directions in coronary physiology. And this is a very timely topic because we are at the verge of a big change in physiology, both at the level of the epicardial vessels and at the level of the microcirculation. And I have entitled this talk also second generation physiology, because you will see that what is happening is that we're going to a further understanding of the coronary circulation in general using the physiology methods that we have. So let's start by just putting this in context. And we have two clear compartments in the coronary circulation, which of course is meant to be educational and for us to be able to study this separately. But what is also true is that this has to be seen as a continuum of anatomy and of course physiology. But for the sake of this presentation, we're going to divide this into two big compartments. On the left side of the screen, you see what we call the epicardial compartment or the epicardial vessel. And in the right side, the coronary microcirculation. We're going to start with the epicardial compartment because we have quite some exciting advancements in the field of the analysis of the epicardial vessels. And to really start talking about the epicardial physiology, I have to go back 40 years and look at the first paper of Andreas Gruentzig, who actually is the one who created our field. And when we look at his paper in the New England Journal of Medicine, the year 79, and we see how he dilated for the first time in using a percutaneous approach, a left anterior descending artery, it's striking to see that if you go further in this paper, you see for the first time an intracoronary pressure pullback performed again 40 years ago. It's not only the pullback, it's the fact that Andreas Gruentzig saw that that lesion, that was the first lesion treated, was actually a very focal disease when he looked in the pullback. And you can, what you see in the screen is actually the right side of the pullback in the proximal part of the vessel. And you see very nicely here how that lesion created a pressure drop in the proximal part of the coronary artery. If we continue looking at this paper, you will not be or will be surprised by looking at the fact that also Andreas Gruentzig measured pressure after performing the balloon dilatation. And this is extremely important because he understood from the very beginning that angiography can sometimes be deceiving, and the best way to assess our results is by measuring physiology post-PCI in this case. And this is what you see in the screen. And that time, of course, there was no FFR. He just measured the mean pressure gradients in millimeter quick across the lesion that he just treated. Today, we can say that this is, of course, post-PCI FFR. So in a way, I like to say this, that we're going back to the future. And we have started to use FFR in FAIN trials and the other validation studies in a way that we measure one FFR per vessel. And this FFR was used to assess lesion significance. This lesion significance was based on a cutoff, and that was the place where we were in the first group of studies. But what has happened in the meantime is that we have really understood that there is a value of physiology to further guide our treatment by evaluating whether the disease that we're treating is focal or is diffuse, and of course, concerning PCI optimization. So we will agree, I think all that we are looking at this webinar, that the pullback curve should be at the core of the clinical decision-making what concerns percutaneous revascularization. Look at these two examples. Case 1 on the left side of the screen, it's a male, 59 years old, angina, class 1. And look, the FFR is positive, is 0.76. But when we look at the pullback curve, this is a completely diffuse disease. There is no single point in this coronary vessel where you can see a focal step of the pressure that could theoretically be the target for PCI. If we do PCI in this type of disease, we will have low post-PCI FFR, and this is likely that the patient remains with angina. So we believe that this type of disease is better treated with medical therapy. On the opposite is the case number 2. This is, again, a male, angina class 2. The FFR is 79, but look at the pullback curve. There is a clear step in the pullback curve here, and this is the place where we can place our stent, and this patient will be likely free of angina after PCI. So this is a perfect indication for PCI. But in practice, it's not so easy. I think that Fernando's in the Cathlab, also Angel is around, but all of you can see a number of pullbacks on the screen. And if I ask my colleagues if this is a diffuse or focal disease, we all agree that this is diffuse disease on the top left upper corner of the screen. If you go to the other opposite, I don't think that nobody will argue that this is a very focal disease. But let's start looking at this intermediate pullback. This is reality. Is this focal or diffuse disease? Or this one, what about this one? Is this focal or this diffuse disease? One more, this is focal or this is diffuse disease? So sometimes when we look at these pullbacks and try to assess them visually, it's very difficult to understand whether the pathology that we're treating is actually focal or diffuse. And it's not a surprise that when you try to look at this pullback, it's like looking at the dogs and the muffins in this slide, and it's very difficult to know very quickly what is the muffin and what is the dog. So we can conclude that the visual interpretation of pressure pullbacks has a high inter-observer variability. And this, of course, increases the uncertainty in clinical decisions. And this was the rationale for us to look for a way to quantify the information coming from the pullback curve. And this is why we, a few years ago, we developed what we call the pullback pressure gradient index, or the PPG. And this is actually an algorithm that accounts for both types of disease within one formula. It accounts for focality on one side and for diffuseness. The way that the algorithm does this is it takes the pullback curve, and then it has a moving window. And in this moving window, the algorithm selects the maximal pressure gradient across 20 millimeters of the pullback. And the second component addresses the length of disease, or the extent of the disease, by counting the millimeters of this pullback that have an FFR deterioration. This is put in a formula that we have described a couple of years ago in the Journal of American College of Cardiology, and this results in the following. The PPG then becomes a diagnostic tool to further stratify the patients with hemodynamic significant lesions in two groups: the patients with focal disease, that is high PPG close to 1, or patients with diffuse disease, that is low PPG close to 0. And you can imagine what are the clinical implications of having a high or a low PPG. This is extremely easy to perform in the Cathlab. I will show you a small video on how we do this in clinical practice. All you need is the Abbott pressure wire, you need to have the Coroventis console, and you need to induce hyperemia either with IV adenosine, regadenoson. Here in ALS, we use intracoronary papaver. Sorry. The way that we do this is by performing a slow and steady pullback. This takes about 20 to 30 seconds. And you see on the screen that while you're pulling back your wire, you start seeing the changes in pressure that occurs inside the coronary artery. And then when you have finished your pullback, when the pressure sensor reaches the catheter tip, you just stop the pullback, and this is your pullback curve. Here, we're annotating the type of vessel that was treated, the phase of the procedure, the hyperemic agent. And once we have identified this, we click on this button, that is the PPG button in your Coroventis console. And in this case, you'll see a PPG that is 0. Let's wait that she appears on the screen. So the PPG in this case is 0.75, indicating that this was actually a very focal disease. And when you look at the angiography, it looks like rather diffuse. So we have found a way to understand in a quantitative way if the disease that we're treating is focal or is diffuse. And why it's important? I'm going to show you why it's important. This is a plot that actually shows in the x-axis the PPG. Again, high PPG represent focal disease, low PPG diffuse disease, and in the y-axis you see the delta FFR. In other words, the change in FFR with our PCI, and this is an extremely important metric. What you see here is a very strong relationship between the PPG and the change in FFR. And we see that in focal disease there is a big change in FFR, while in diffuse disease the magnitude of the change is relatively small. If we look at this with statistics, this is what we found. There is an excellent predictive capacity of the PPG to predict the change in FFR with an area under the curve of 0.83. If we look at this now in other type of statistics, like for example, the coefficient of determination of the R square, we see here that is 0.46, and that can be interpreted as that the result of PCI depends in almost half on the baseline pattern of disease. Of course, the other half refers to the PCI itself, but look how important it is to assess the disease before the procedure to understand what would be the potential benefit of our stent. And this is very exciting data. What you see now on the screen, this is the sub-analysis of the target FFR study, looking at the relationship between the PPG and angina post-PCI. And what you see on the screen are the results of the Seattle Angina Questionnaire. This is a common questionnaire to evaluate or to quantify the symptoms of the patients in 3 domains. The Seattle Angina Questionnaire of 7 items has the angina frequency domain, the physical limitation domain, and the quality of life domain. And we have to stratify here the score of these patients according to the focality of diffusion of the disease based on the PPG. The higher the score, the better the patient is. The lower the score, the worse the patient is. And you see here, what it strikes me about this information is that when I have a patient in my consultation that have symptoms, it's impossible to say whether the patient has focal or diffuse coronary artery disease. And you can see that there is no significant differences between the scores of quality of life, angina frequency, or physical limitations between patients with focal or diffuse disease. But now look what happened at follow-up. So we re-administer the questionnaires 6 months after the PCI, and look what happened. Patients with focal disease defined by the PPG are the ones saying that they have no more angina after PCI. And look, the patients with diffuse disease has almost no improvement what concerns angina frequency when treated by PCI. The same results are observable and with significant difference between the terciles when we look at physical limitation, also much better in patients with focal disease treated by PCI, and also what concerns quality of life. When we look at this, not in absolute value, but we look at the change in the Seattle Angina Questionnaire, this time stratified by the PPG, here's what we see. If you look at the angina frequency domain, look at this. The length of the arrow actually it portrays the improvement of that patient. The longer the arrow, the higher the improvement. Look at this. The improvement in terms of angina frequency in patients with diffuse disease defined by the PPG is very small, in contrast to what we observe in patients with combined or diffuse disease. If we look at the physical limitation, it's more or less the same value, the same information with very small improvement or no improvement at all in terms of physical limitation in patients with diffuse disease treated by PCI. So we have found a way to further identify which are the best patients that can be treated with PCI. And of course, we have identified also one of the causes of the reason of persistent angina after PCI. And the most important thing about the PPG is that this is available before you implant your stent. So you can take a more refined decision-making, more personalized decision-making before you actually undergo in a PCI in a patient with stable coronary artery disease. So this is the news that we have for the epicardial compartment. Now we're going to look a little bit more at the microvascular compartment, and this is the focus of the next part of the talk. It's not a surprise that we're talking about this today. I went into PubMed a couple of days ago and look at this. So when you put coronary and microvascular disease, there is an increasing amount of publications, and there is, of course, a lot of interest in the field of the coronary microcirculation. And we have published this, it's going to be in press next week, which is a meta-analysis assessing the prevalence of CMD. And look what we found. This is including more than 14,000 patients. And when you look at this, you see that in patients with non-obstructive coronary artery disease, either defined by angiography or by an FFR more than 0.8, approximately 42% of these patients will have microvascular dysfunction or coronary spasm. So this is a huge part of a huge proportion of the patients that we see in the cath lab that we think are healthy because we don't see anything at the level of the epicardium. Based on this result, I think it's urgent for us to understand that as clinicians, as interventional cardiologists, when we have a patient that is symptomatic, that is sent to the cath lab and we don't find anything at the level of the epicardium, this is the moment where we need to assess the microcirculation to understand if the disease is located in the small vessels. The second message from the analysis that you see on the screen is the high variability in the prevalence of CMD. You see here, not surprisingly, that some of these bars barely reaches 15%, while other bars go to almost 70%. So the prevalence of coronary microvascular disease is very, very variable. And this, of course, is related to the lack of standardization in the diagnosis criteria for CMD. So I like the title of this editorial because we are really having a macro confusion about the coronary microcirculation. And this refers to the number of methods that we have to assess different parts of the coronary circulation, and sometimes it's really difficult to interpret the result of these findings. You can see here on the slide that there are several non-invasive methods that allow us to assess the coronary microcirculation in one way or another, but there are also some invasive methods that allows us to more selectively assess the coronary microcirculation. Perhaps the most known index to assess the coronary microcirculation is the coronary flow reserve of CFR. This is a very straightforward index, and I show you one of the first tracings using Doppler wire to assess CFR. And this is just a ratio between the blood flow velocity at baseline and the blood flow velocity that increases with the hyperemic stimulus, in this case, using adenosine intracoronary of 200 micrograms. And you see here the increase in the flow velocity, and the coronary flow reserve will be then the ratio between the velocity and hyperemia divided by the velocity in rest. And this points at how many times can the flow in your coronary circulation increase during a hyperemic state. And this is partially a metric of the microcirculation. But the problem with CFR is that it's really specific. So if you have also a problem in the epicardial compartment, if you have epicardial resistance, this will also reduce your CFR. So the problem, this is the main problem with CFR, that is not specific for the coronary microcirculation, and therefore is very difficult to interpret in the presence of epicardial disease. We have a more selective method to assess the coronary microcirculation that had been used more and more in the last few years, and this is the so-called IMR, or the Index of Microvascular Resistance. And this is a method that is based on Bolus Thermodilution. Very quickly, I'm going to give you a crash course of 30 seconds of Bolus Thermodilution and how this actually works in the cath lab. What you need to know is that the wire that we use, that is a pressure and a temperature wire, actually has two sensors of temperature. One sensor that is in the proximal part of the wire, and another sensor that is in the distal part of the wire. So by convention, when we inject, let's say that we inject 3 cc of saline that is at room temperature means lower than the temperature of the blood, and we pass that bolus of saline through the first thermometer, what we're going to see is a curve with a reduction in temperature sensed by the proximal thermometer. And when this saline goes further down the vessel, of course, the same will happen when this saline bolus reaches the distal sensor, and it will give you another curve. And then we can have the time between the first curve and the second curve, and we name this mean transit time, and this is a surrogate of flow velocity assessed by Bolus Thermodilution. This is what we see in the screen, and I show you the case, a typical case of a patient with coronary microvascular disease. I just want to show you and highlight this, that here you see the mean transit time. So we make 3 injections. I'm going to show this in the next slide, but just to show you how this is actually seen in the Cathlab by the mean transit time in rest, and then you have the mean transit time in hyperemia, and you see that the hyperemia is significantly shorter than the one in rest. And we're going to understand how these numbers are used to assess our coronary microcirculation. To assess this is very simple, and we'll see a case later on, probably using continuous and maybe also bolus thermodilution, but you need the pressure wire, which is actually pressure and temperature, as we have said. We need a hyperemic agent, of course, and we need the Coroventis console. And then the hyperemic agent can be intravenous adenosine, can be regadenoson. Again, here in ours, we use papaverine, 12 milligrams for the left coronary artery and 8 milligrams for the right coronary artery, and this we do with intracoronary. I'm going to show you a video very quickly for you to understand how bolus thermodilution works. This is our Cathlab. I'm here with Bernard on the Cathlab, and here we're making the injections. And you see how every time that I inject using this 3 cc syringe, you see this temperature curve on the screen. And this time that is, you see on the screen, 29.31 and 0.29, is just the distance between the 2 curves that we have discussed in the previous slide. And then we use this in rest. So we use this to calculate the resting mean transit time. And then we induce hyperemia. After we have induced hyperemia, we do exactly the same. So we inject 3 times the bolus of saline to assess the mean transit time now in hyperemia. Technically, there is a couple of tips and tricks. I always flush 2 times before starting the measurements again, because sometimes the saline that is in the catheter might have been warmed by the fact that we're waiting for the hyperemic agent to make this effect. So I just flush my catheter to be sure that the saline that I'm going to inject for the IMR calculation is actually at room temperature. And this is how it happens. And it's very, very fast. It's very, very short. So here comes the first injection, and you see there that I got a value of 0.29. And then I repeat another 2 injections. And this in overall takes about 3 to 5 minutes. So this is the extra time that we did in the Cathlab to assess the coronary microcirculation. Look at what happened in this case. We have 22, 9, and 14, and these values have actually very high variability. So how come the first mean transit time is very, very prolonged, or is twice of the second mean transit time? And this is one of the downsides of bolus thermodilution, that is relatively variable and depends, of course, on the injection of the operator. So what the company tells us to do is to replace the first, or the outlier. In this case, the outlier was the 22. So here what I'm going to do is just select the 22 on the screen. And then after I have selected this number, I'm going to make a new injection. And here I'm doing a new injection. And then I should get a mean transit time that is more likely the 0.09 or the 0.14. I got 0.12. But you see how this could add some variability to the measurement that we're doing to assess the coronary microcirculation. In this particular case, you see here that the IMR is 9, meaning that there is a normal microvascular function, and the cutoff of the IMR you have probably already know by the consensus, but is in stable patients 25. And when we are faced with this screen, there are a few things that we need to know, and everything is very straightforward, but I will have to tell you also when you are analyzing a few tips, is that we have to play this line, which is the line of the PD here, in a stable position, in a position where the PD doesn't fluctuate too much. And this, of course, will give you this 64 here, which is very important for the calculations that will follow. The second thing that you will see here is that we have the average of this resting mean transit time. These are the blue curve. So this is the average of the time that it takes to acquire this blue curve. And next to it, you see the line that the yellow lines that were the injections performed during hyperemia. You see again that this is significantly faster in terms of this, the units here in seconds. It's very easy then to understand where the CFR comes from. So the CFR in this case is the resting mean transit time divided by the hyperemic mean transit time, and in this case is 1.8. And the IMR is just an index. It's not a measure of resistance. It's an index that is actually obtained by multiplying 64, that is the distal pressure in the coronary artery, by the mean transit time in hyperemia, that is 67, and you get this 43 on the slide, that is actually a patient with coronary microvascular dysfunction. But we are one step ahead already. As you have seen, there is some variability, some operator dependency on the measurements of IMR. So in the last few years, and I think the first publication is in 2007, so almost 13 years ago, Bernard de Bruyn and Nico Pels start working on another way to assess the coronary microcirculation, this time using the same principle of thermodilution, but instead of doing bolus injection, we're infusing in a continuous way saline through a specific catheter, and this will allow us to understand what is the specific flow in that vessel. And beyond the flow, of course, if we know the flow and we know the pressure, we can also have, for the first time, measurements of resistance in Wood units in that specific myocardial territory. To do this, you need what you have on the screen. You need this dedicated infusion catheter that is for the company Cath. The catheter is called Rayflow. And this catheter has actually 4 points where they have 4 jets of water, of saline coming out the catheter. And this is actually what generates the hyperemia. You need a pump injector that has to be programmed at 10 or 20 milliliters per minute. We're going to discuss this further. And then you need the Coroventi software in the absolute flow setting. And I think we're going to see a demonstration just after this presentation. How we calculate the flow is very easy. It's based on the thermodilution principle. So we actually take the temperature of the TI refers to indicator. That is the first nomenclature used when the thermodilution technique was first described. And then we have the temperature of the mix that comes in the denominator. And this is multiplied by the infusion rate. In this case, we know the infusion rate because it's in the med that pump, in this case, 20 milliliters per minute. We multiply that by a constant that is able to translate, to adjust for the fact that we're using saline and it goes to the blood. I'm talking about the temperature, and then we're going to get the flow in that specific vessel. We're going to see how this works, and you will see how easy is this technique. The first thing you have to do is you have to wire the vessel. You have to put the catheter in the proximal part of the vessel, and this is, of course, the place from when the flow measurement will start. So we always record this black dot that is coming here, which is the position of the jets that I showed you before, and then you start your infusion. When you start your infusion, this is what you're going to see. First of all, this is a 20 milliliter per minute infusion. You will see that the temperature line start going down. Of course, the saline is colder than the blood. So you will see here that there is a decrease in the temperature sensed by the sensor or look at by the sensor in the distal part of the coronary vessel. Then what we do, so we have already the temperature that is the mix of saline and water. And now the only thing that we need to do to fulfill the thermodilution equation is the temperature of the indicator, of the temperature of the saline in this case. So what we do is a very simple maneuver of a pullback. And when we do the pullback, you will see that the sensor that is actually in the transition of this radiopaque part of the wire to the other part of the wire comes very close to the jets. And at this time, this is what we see. So this fall here in temperature is just the moment that we're pulling back the wire. And then you will get here the temperature of the indicator. So now we have the temperature of the saline in the numerator, the temperature of the mix, blood and saline, that is here. And then we know the infusion rate because we have programmed that in the pump. So with this information, we can derive, in this case, absolute coronary flow. in this case is 148 milliliters per minute. And if you look at the resistance is 507 Wood units. So this was the first, let's say, approach to measure absolute flow. Then a couple of years ago, we realized that we were also able to measure resting flow. And I have to say, and I think Fernando and Angel would agree, that resting flow is the Achilles heel of most of these techniques that require indexation for the baseline flow, because it's very difficult to measure resting flow in any condition, especially in the cath lab. The patient is never at rest. Is a stress, is in the cath lab, he has a catheter inside, has been punctured, etc. So this is always a problem. So what we decided to do was to test the hypothesis that using continuous thermodilution, it would be feasible to measure resting coronary flow in a reproducible way. So what we did, and I will, for the sake of time, make this short, we found an infusion rate that actually does not influence the pressure ratio, or in this case, the blood flow velocity. This is average peak velocity measured by a Doppler wire. So what we did very quickly, we put a Doppler wire in the vessel. We started an infusion, not of 20, as I showed before, but of 10. And we saw that there was no increase in flow velocity whatsoever, meaning that at 10 cc per minute, we were still in resting conditions. And then we just increased the speed of the saline and we went to 20 milliliters per minute. And you can see clearly how there is a higher degree of hyperemia, both assessed by of course, by the pressure gradient, but also by Doppler flow velocity. We went a little bit further and we compared the CFR that was derived, because then we have resting flow, we have hyperemic flow, both measured with continuous thermodilution. And of course, we have the same two states derived from the coronary flow velocity using the Doppler wire. And look at the correlation between the CFR derived from Doppler and the CFR derived from continuous thermodilution. I have to say that when you compare these plots with the plots that were done in the past, comparing Bolus Thermodilution with Doppler, this is a tremendous a step forward in the sense of the reproducibility and the correlation that we're observing with Doppler wire. So in practice, what happened, I'll show you a case where you do the same two maneuvers. This is a calculation of resting flow and resting resistance. So for the first time, this tool allows us to understand how is the resistance and the flow in resting conditions. And look, I'm gonna go slowly in this slide. So we started an infusion of 10 milliliters per minute of saline. This is an LAD. You see here in the Coroventis, we have set the infusion rate at 10. The infusion started here. You see that when we achieve a stable temperature here is the moment we say, okay, we're stable, and then we're ready to do the pullback. We do the pullback, we see the temperature here, and we let just the temperature curve recuperate. And again, if you remember the formula that we have to derive the absolute flow, in this case in resting conditions, here you have the temperature of the indicator that is measured here. Everything is shown here in the Coroventis. This is the temperature of the mix of the saline and the blood, and then you just change this into your equation. Here you have the temperature of the indicator, which is 3.16, shown by the Coroventis. Then you have times 10, because 10 is your infusion rate, divided by the temperature of the mixed saline and blood, and this will give you the flow. The flow in this case is 68 milliliters per minute, and then you see the very high resistance, or the high resistance that you see in rest compared to the previous case that is showing hyperemia. But in the same case, then we now change the infusion rate to 20, and then when we change the infusion rate to 20, here's what we see. Of course, the decrease in temperature is higher, both by the one in the indicator and the one at the level of the mixed temperature. And this is what we get. So you see how nicely we have demonstrated that the microvascular resistance decreased significantly in hyperemic conditions just by comparing the absolute flow in rest and the absolute in hyperemia. And if you remember the previous slide, the resistance in Wood units was about 1400, and looking hyperemia, it went down to 386. So we can conclude that this patient had actually a very high or a very good vasodilatory capacity of the microcirculation observed by the significant fall in resistance in hyperemic conditions. Based on this ratio, we have described a new index that we call microvascular resistant reserve. We call it MRR, and this is the first specific index of the coronary microcirculation derived from the absolute flow measurement. The formula is pretty easy. So MRR is just the flow measured during hyperemic conditions, the one I just showed you, divided by the flow that we measure in rest, and then we actually adjust that by the FFR. And this is the MRR, and the MRR can be interpreted as the number of times that the hyperemic, that the resistance in the coronary can be reduced by when we induce hyperemia. And then we have gone one step further, and this is where we're testing in a new clinical trial. We call this the Aerocraft, where we have completely automated all these measurements. So to understand all the complexity that is on the screen, I have to tell you first that you, as an operator, you don't have to do anything in the Cathlab except a small pullback maneuver. What you see on the screen is actually almost completely automated. And I'm going to explain you what we have achieved. And this is extremely important because this makes the measurement of the resistance in the circulation fully operator independent. And this is what happens. So again, we're going to focus on the inferior panel. The superior panel, just for clarifications, are the pressures measured by the sensor. So here in the inferior panel, we start at 0 temperature. The temperature is the same. We start an infusion of 10 milliliters per minute of saline. Here you see that there is a small decrease in temperature. At this level, the pump automatically switches to 20 milliliters per minute. And this is the reason why you see a further decrease in temperature here. And then when we have achieved stable temperature with the new infusion of 20 milliliters per minute, we just perform the pullback. We perform the pullback, and what is the information coming from the pullback is the temperature of the saline when it comes in the coronary vessel at 20 milliliters per minute. We hold this for 20 seconds, and after this, the temperature recuperates and change again to 10 milliliters per minute. And with these two informations, we actually can assess the complete coronary circulation in resting and hyperemic conditions, and this takes 4 minutes. So what you see on the screen again is the calculation of the flow in hyperemic conditions on the bottom and in resting conditions on the top. And here, of course, you can calculate CFR, MRR, and of course, absolute flow and resistance, both in resting and hyperemic conditions. So we are at the verge of a real change and a real progress in the field of coronary physiology with the so-called second generation physiology. So we have had a transition from FFR to PPG, which is a kind of a second dimension of FFR. And in the microcirculatory space, we have come from unspecific metrics of microvascular resistance like CFR and IMR to a fully operator-independent technique that is able to assess, as mentioned, absolute flow and resistance. So I would like to conclude that the second generation physiology assessment, this includes the PPG and MRR, absolute flow, expand our understanding of both the epicardial and the microvascular disease. And of course, this has therapeutic implications. We now know that patients with focal lesions defined by the PPG are the best candidates for PCI. And PCI and diffuse disease do not improve angina. I will probably have to embark now in a new era of interventional cardiology where we're going to look beyond the single point FFR, the single point RFR, to now look at the pattern of disease to refine the appropriateness of PCI, avoiding PCI in patients with diffuse disease. And the advent of coronary thermodilution, especially with the absolute flow, absolute resistance, and MRR, represent a novel, reproducible, operator-independent metric that is specific for the microcirculation. And I'm pretty sure that this will allow not only for standardization, but for also to understand a little bit more about this black box that is the coronary microcirculation. Thank you very much for your attention.
Thank you, Carlos. Can you hear me?
Yes, I hear loud and clear.
Okay, Carlos, thank you very much for your spectacular presentation. Very, very, very nice in both components, epicardial and microcirculatory component. And now, without further ado, we will present you the case. Dr. Abellas, we will present the case.
So, good afternoon. Today's case is a 63-year-old female with no cardiovascular risk factors and the previous rheumatoid arthritis treated with tocilizumab. So the patient refers chest pain for the last few months, and she was admitted in 2002 because of chest pain to the cardiac care unit. In that moment, she presented with ST segment depression and elevation of cardiac biomarkers. A coronary angiography was performed showing no significant coronary artery disease. And because of these new chest pain episodes, the thoracic echocardiogram was performed, showing normal left ventricular ejection fraction with no segmental wall motion abnormalities. And a perfusion imaging was performed also with no results. So these are images from today's coronary angiography with, again, no significant epicardial disease. And now we're going to do the microvascular study.
And with Pablo from Abbott, and we will show you the case. Fernando or Ana, can tell to Carlos the...
Carlos, buenas tardes. Cambiamos a español, que vamos a estar aquí más cómodos. Bueno, no sé si estáis viendo los hallazgos.
¿Puedes ver la imagen nuestra del Cathlab?
Sí,
hemos
los
hecho
veo ustedes. Sí.
Un estudio de termodilución en bolos con CFR y MR y hemos visto unos hallazgos bastante espectaculares, ¿no? Con un IMR muy elevado, un IMR de 74 y un CFR bajo de 1.7.
Fernando, perdón que te interrumpa, no veo la pantalla de Coroventis, veo solamente el electrocardiograma.
¿Podemos ver la pantalla?
Espera un segundito, ahora te lo mostramos. Ahora, Carlos, ¿lo puedes ver?
No, veo el polígrafo con la presión, la geografía y los veo a ustedes.
Y ya está. ¿Puedo poner este solamente? ¿Dale aquí?
Ahora lo veo, perfecto.
Ahora. Vamos, como puedes ver, las curvas, la doctora Pardo tiene un pulso estupendo y un agreement perfecto, ¿no? Digamos, tiene un tiempo de reposo de 1 y una hiperemia de 0,60, que es alto, con presiones distales altas, con lo cual nos sale un IMR muy elevado. Vamos, que no hay mucha duda de que estamos ante una disfunción microvascular. No sé, ¿tú qué piensas?
Bueno, primero déjenme felicitarles por la calidad del trazado. Las curvas de termodilución son excelentes. Veo que la reproducibilidad de los números es fantástico, 66, 65 y 60 en hiperemia está perfecto desde el punto de vista técnico. Ahora lo que dice Fernando, estoy completamente de acuerdo contigo. Vemos que hay un IMR que es, en mi experiencia, súper alto. 74, no es frecuente encontrar números tan altos de IMR, pero yo creo que sin duda esto es un hallazgo muy importante. Me gustaría también preguntarte, porque veo que hay muy poco cambio en relación al PDPA y al FFR, estaba en 96, 97. ¿Qué agente hiperémico has usado?
Estamos con adenosina, 140 microgramos kilo. De todas formas, como había dudas de si hubiera dado tiempo a hacer la hiperemia, hemos hecho un IMR, si quieres ponerlo, un IMR solo esperando un poco más y los resultados no cambian. Es ese. Un poco menos de refluidicidad, vamos. Sigue siendo un IMR bastante elevado, de 65. Estoy esperando 5 minutos más por si no hubiera dado tiempo a hacer efecto la adenosina. Bueno, si os parece, vamos a empezar con la medición del flujo absoluto con termodilución continua. Entonces, aquí tenemos el catéter dedicado, del que Carlos ha hablado antes.
¿Se puede enfocar al catéter desde...?
No sé si lo podéis ver, dar la luz incluso. Entonces, vamos a empezar a purgar. Es muy importante purgar el catéter, obviamente, para que no entre luz y luego ver esos 4 chorros, que no salga pulverizado, que quiere decir que tiene una presión adecuada.
Enseña la
bomba.
cámara que está ahí.
¿Dónde está la cámara? Ahí está. No sé si se ve. Ahí están los 4 chorros. Es una de las características por lo que este catéter produce una mezcla homogénea de temperatura en la arteria coronaria. Me toca a mí que no veo.
Claro, mientras estamos en esto, ¿en qué fase está el tema del PPG, del PPG, para pensar que lo podamos tener a nivel clínico? ¿En qué fase está de research, de estudios clínicos?
Bueno, ya hemos realizado 2 validaciones clínicas, estamos en la tercera que le llamamos el PPG Global, son 25 centros a nivel mundial, vamos a incluir 1000 pacientes, ya tenemos 250 pacientes incluidos, va muy rápido y yo creo que muy pronto esto estará disponible para usarlo dentro de la plataforma de Coroventis para todo el mundo. Es importante que sepas, Ángel y Fernando, que ya el PPG tiene CE Mark. Esto puede ser usado ya en práctica clínica, pero estamos todavía terminando la validación prospectiva para poder tener datos bastante fuertes para la aplicación en la práctica diaria.
Pues una gran noticia. Bueno,
Más.
Cuéntanos ahora.
Bueno, ya hemos avanzado, como veis, en el microcatéter, lleva una marca radiopaca en el extremo distal y hay que saber que es desde ese punto exactamente desde donde mide el flujo coronario y la resistencia. Es decir, si ese punto está en el tronco, mediremos el flujo del tronco. Si lo metemos en la DEA proximal, que es lo que hasta la fecha está más estandarizado, obtenemos el flujo en ese punto, en la DEA proximal. Pues yo creo que el sitio es bueno, está en la DEA y vamos a empezar con una infusión a 20, súbelo a 20, por favor. Que como hemos visto antes, por encima de 15 mililitros por minuto vemos que produce hiperemia.
Fernando, he visto que alguien ha hecho clic en el botón de Zero Temp. Esto es un paso importante.
Sí, se nos olvida muchas veces y es muy importante hacer el cero de las presiones, además de ecualizar las presiones, hacer el cero de la temperatura aquí, porque a diferencia del IMR, que es un valor relativo, aquí es que es muy importante el valor absoluto de los grados que baja.
Fernando, entonces, Ángel, estoy leyendo aquí el chat y tengo varias personas pidiendo que volvamos a hablar inglés, que varios no entienden español.
No hay problema, volvemos a
no problem.
Lo siento.
Okay, so what you have done so far then is that you have put the wire distally. We have seen a small black dot that is actually the tip of the catheter where you have the 4 jets coming out. This is the place, again, Fernando just mentioned, where you will induce or where you measure the flow and the resistance. And now, Fernando, what are you doing now?
So we are infusing saline through the microcatheter, and we have just about 2 minutes, and I think that's the temperature. Huh? I think it's steady, so we can retrieve the wire into the catheter.
So look at this, it's a very important step. So he has stable temperature, then he pulls back, and then he stops at the level of the microcatheter. Very good.
Okay, that's the infusion temperature, and now we want to wait till it gets 0 again to have a nice curve.
Very good. So, Fernando, sometimes people ask me that if this is difficult to perform, and I have to say that looking at you, this is probably one of the easiest techniques that we have in the Cathlab to measure physiology, I think.
Yeah, I completely agree. It's really easy. You just need to cross the wire in a often absolutely normal coronary artery, and you just need to put the microcatheter through the wire and just measure. It's really easy to perform. So we have the results there, and we have a minimal resistance of 300 which is not, in my experience, because we don't know. This is one of the problems with these indexes, is that we don't have normal values established. We have not reference.
In the few studies, this is a low value. It's not because the cutoff, Carlos and Fernando, is about 500 or 400.
I think for a proximal LAD, it's about 500, a really pathological value. But of course, we have this is the result. It's really discrepant with the IMR. We can now, if you want to perform the basal flow, you have to put the wire in the same place. You have. And one important thing is you can see the FFR is almost the same that we obtained with the adenosine. So we have performed hyperemia with the saline infusion, but we have these values. So
let me tell you what I think. This is extremely interesting because you have a bolus thermodilution technique showing a clearly abnormal value. Then you have performed in a couple of minutes absolute flow, and you have seen that actually the resistance. And I agree with you, Fernando. We're in a moment now that we don't know the normal values, but I agree with you too that 334 is not so high. We have seen resistance, for example, in territories that had infarction around 500, 600. So 330 doesn't appear to be such a big resistance. Do you have any thoughts on why the absolute and the bolus thermodilution information might differ from each other?
Well, I don't have a clear explanation, but I think that the pressure is here has a main role, because it was really high to the distal pressure when we measure the bolus thermodilution values, and it's not so high now. This is one of the points. And the other hand is that we are measuring the same thing, but we do different techniques, and we have to be which of them is more accurate, but we don't know really that right now. So we're going to measure the basal flow. So we need to make 0 and change the infusion rate to 10. We can begin the infusion. Okay. Another point, I don't have seen the angio right now. Another point is that we have, probably we have measured the left main flow. It's another explanation.
And Carlos and Fernando, if you perform the same technique, not in the prox LAD, in other artery, circumflexor, RCA, would you expect the same results or different? Because you are evaluating only a area of the heart, in this case, the biggest area. But do you expect to have the same results of regarding the resistance, a low resistance in circumflex or RCA? We will have to do it, or what's your opinion?
Well, so we have seen that they are really different. One point of these new values is that they are dependent from the myocardial mass. And of course, if you have more myocardial mass, as you have in the LAD, you will have higher flow rates and lower resistance. And that's why they describe this new index, the MRR, which is theoretically independent from the myocardial mass.
We need an update of the hour shower to calculate these indexes.
So what we are seeing now, this is the results of the resting flow. Yeah. As you can see here, the resistance is higher, of course. We're in resting conditions. The resistance will come higher and the flow will be less. What I'd like to know, Fernando, can we go? I see 189 milliliters per minute. how much was the hyperemic flow? Can you go back to the previous screen?
Review.
I don't remember.
Review.
Because we have now resting flow. If we have hyperemic flow, you go down. Yes.
Okay. Huh? Okay. That's it. Okay.
So you have here 368, and I have my calculator next to me. I will do this for you. This will come
around 2.
1.9. So
okay.
So CFR is 1.9, derived from absolute flow, both resting and hyperemic. And I have also here look at the MRR, which when the FFR is 1, the CFR and the MRR is the same. Okay, this is an important concept. So now the MRR in this case is 1.8, meaning that, yeah, there is using MRR or CFR, there is, let's say, a microvascular dysfunction. So this again goes in line with what we have observed with the IMR. What is a bit not clear, and again we have to be clear that we have not a cutoff, is that the resistance appear to be normal. So this is where we are. I think that you have done a wonderful demonstration on how easy it is to perform these measurements in the Cathlab. And again, Fernando, I think that probably you have done almost nothing. This is the beauty of this technique, that can be done by anyone and is relatively or completely operator independent. I don't know if you agree with that statement.
I completely agree, and it's a nice case. We have seen the utility of the new index that you have described recently in Jack, and of course we think that this will be the future of the microvascular function investigation.
I have a maybe silly question for Dr. Collet or Fernando. My name is Marcelo San Martin. I'm talking from Ramón y Cajal. Is there any difference performing the continuous infusion with the catheter with the rate flow first at 10 milliliters minute and then at 20 milliliters minute, instead of doing the hyperemic flow first, examining the baseline flow and then the hyperemic? Is there any difference in final results?
No, we have looked at that specifically, and there is no difference. So of course, you have seen that Fernando did the hyperemic measurement, then he waited until the resting conditions came back, and that is the moment where he started measuring the resting flow. So if you are careful enough to wait a little bit to let the patient come back to resting conditions and do it again, there is absolutely no problem. I have a question probably for you, Angel and Fernando, now more clinically oriented. So you have a patient now where you have clearly shown that this patient has microvascular dysfunction. How would you treat this patient medically?
Before this, Carlos, do you perform acetylcholine testing to assess the vasomotor function or not? Or you?
Yes, we do it routinely. So when the patients come to our microcirculation clinic, we perform both. Yeah, we
will perform it in a few 1 or 2 minutes, and then we will answer the question, your question.
Perfect.
So we are beginning the acetylcholine test with the first injection.
I believe maybe the clinical response to different drugs might depend on what type of angina the patient has. If she has a effort angina, you might select one agent such as beta blocker, the Cormica trial, or calcium antagonists. Most of the time, we prefer to use the hydropyridine calcium antagonist because we really see a very better response compared to beta blockers. Obviously, it varies from patient to patient. And this type of disease, the microvascular angina, is also episodical. Patients experience periods of months of severe symptoms and then go asymptomatic another year or two, and then come back to the clinic with angina. I don't know if you agree with that, Dr. Collet.
I fully agree with that comment, and I think it's very patient specific. I think that the proposal of Angel to weight the acetylcholine test is correct in the sense that it can help us further tailor the approach in terms of medication. But it's also true that all this first, second line therapy are based on anecdotal reports. So we are now ready with this type of tools to start randomized comparisons with medication in different endotypes of microvascular dysfunction. It is something that we will surely will be collaborating among a lot of centers to understand what is the best therapeutical approach with a good level of evidence to know how to approach this patient from the therapeutic perspective.
Now we injected the first bolus of acetylcholine, and there is no changes in the epicardial diameter. The patient has no chest pain, no changes in the ECG, and now we just infuse the second bolus. The second bolus.
What doses did you inject it first?
2 micrograms.
2 micrograms. Very low.
2, 10, 50.
No, 20, 100 and 200 is our protocol.
Yeah.
Is the same protocol that we do in ALS, 2, 10, 100 and 200. And normally we do this over 2 minutes. So especially the high doses, we have to go very slowly because you should not be surprised. These patients sometimes have pauses or arrhythmias during the infusion if you go too fast. So it's always a good advice to go slowly with high dose of acetylcholine. And then of course,
it's a good point. It's frequent to have atrial fibrillation with high doses with you inject very, very quick. Yeah,
so I don't know if you could see the angio, but it's completely normal after the second bolus, and we are now applying the third one.
I'm going to ask you a difficult question, Angela. I have seen that you started with the ray flow and with the measurements of thermodilution, and now you have shifted to acetylcholine. Did you administer at all nitrates in these patients before the first measurements, or when do you do nitrates in this type of?
At the beginning.
At the beginning. At the beginning of procedure, you inject nitro, and after the acetylcholine.
And so this is a bit, I think we have had a couple of debates with other colleagues on what is the best order to do this test, because one concern could be that giving nitrates before the acetylcholine could blunt the spasm just because you have nitrates already on board. And nobody really knows if this is it's affected or not, or how long would this protected effect would last. We do it in ALS in the opposite way of the recommendation of the consensus. So we do first acetylcholine without nitrates. So we don't give nitrates at all. We do the acetylcholine, then after the last dose of acetylcholine, we do nitrates, and then we proceed with thermodilution assessment.
That's a good point. Now in our hospital, we start with frequently with a microcirculatory test, and in the end with acetylcholine. But this is a good option, as you said. Okay, this is the third dose, and
it's completely normal, I think. Patient is asymptomatic.
So then we have the phenotype of the patient. Fernando, tell us about the treatment.
Of course, I think this is a microvascular dysfunction phenotype, so endotype, sorry. So the recommendation is to give her beta blockers and maybe nitrates, but I think that beta blockers are the main treatment that this kind of disease could respond. I don't.
Marcelo, do you agree with the treatment? You are an expert.
I have a different experience, but it's very patient dependent. Frequently occurs for maybe other indications or the disease or combined. But I see more clinical improvement in the office with a calcium antagonist, even if the patients experience angina effort, which would make more sense to use a beta blocker agent theoretically, but in the end, clinical experience has taught me that otherwise. It's my pure experience, and obviously is not based on clinical trials. And it's okay to use beta blockers.
Fernando, Angel, sorry, I'm looking at the ECG from here, and I don't know if you see that over there, but is there some sort of ST depression after the last doses? No.
No, the electrocardiogram is the same as before.
No, no changes, no chest pain, no changes in the diameter of the epicardial vessels. I think the test is completely negative.
Okay, that's a very good point, because don't forget that we're talking about the criteria of spasm angina, spastic angina, which are 3, the same that you have mentioned: chest pain, ECG alterations, and obstruction of the coronaries more than 90% compared to the vessel after nitrates. So these are the 3 criteria. And if you have the 2 positive criteria of chest pain plus ECG alterations without a severe obstruction, we call this microvascular angina.
Yeah, agree. So Carlos, it's 3:07. I think it's a good time to finish the webinar. If you wanted to tell and to say the last home message, the last remark.
No, I just want to first, to thank you all for the invitation. I really enjoy it. I'm happy that we spoke Spanish a little bit. And congratulations again. What you have done today is really a superb case with very nice tracings. The quality of all the tracings that we have seen are excellent. And I think it was very educational. So thank you very much to you and all the team there for this case.
Fernando.
I think the same. First of all, I want to congratulate you and all the Ramón y Cajal Cardiology Service for this nice course. We have enjoyed a lot, and we hope that there will be next year another course. Thank you very much.
Okay. Thank you,
Thank
Fernando.
you.
Thank you, Carlos. It was a pleasure. Thank you very much.
Bye-bye. Ciao.